Hey, Jim Hoffman here for EMS Office Hours. This is your Monday Minutes, and today, as promised, this is part 2 of the EMS Documentation Pearls that I began last week. Now, this week, I'm going to go a little bit more into detail when it comes to specific things that you might be doing for the patient. Now, again, guys, this isn't everything, okay? You might have your own sort of style, or your paperwork or your electronic PCRs might require other certain documentation features, but I'm hoping that these tips that I'm giving here are going to maybe let you focus on some of the more key elements that will make it easier to both defend yourself and explain treatment you're giving or not giving, and also explain to other healthcare providers like nurses and doctors down the line for the patient's continuum of care, what you did for them and what the responses were and things like that. Okay, so let's take a quick overview here of this. All right, now remember, documentation nowadays, guys, has been much more simplified, right? We've gotten to the point where we're doing a lot of check boxes, right? And, you know, pictures to fill out and things like that. But there's still things, even though you're checking boxes, a lot of times you might check a box and let's say you did an EKG, but it gives you an opportunity in most of these electronic versions anyway to add a small comment about that checkbox. And it's important not to just check a box and move on unless that box you're checking is just very general type of information, right? Male, female, things like that, right? So when you're checking some of these boxes that give you that opportunity, remember there usually is a space to elaborate a little bit more on what it is that you did, okay? And might be check boxes and then even sub-check boxes of the treatment and procedures that you're doing. So let's go over what I think are some of the more key elements that we're going to do. Now, this is a little bit longer this week because we're going over some more in-depth content. I didn't want to make this a 3-week, Monday Minutes, but I wanted to go ahead and at least get these two sessions in for the documentation pearls. Let's get into this, okay? All right, intubation, right? You want to talk about the indications, why you did it, right? You want to give the number of attempts at intubation, both by you and your partner. You want to go ahead and note the confirmation methods, right? Whether you did end-tidal CO2, capnography, things like that, okay? And you want to do vital signs. Make sure you document patient's vital signs before and after your intubation, okay? It doesn't, even if they're in cardiac arrest, make sure you note the vital signs before and after, okay? Now, defibrillation and cardioversion, right? Note your pre-shock rhythms, right? Note your energy that you've delivered to the patient. Note your post-shock rhythms. And of course, you want to note the patient response, whether it's positive or negative. What about pacing? Again, you want to put your indication while you're pacing the patient. Okay, sometimes it's because they're bradycardic. All right, sometimes because your protocol might say to pace, let's say, an asystolic patient. Okay, you got to follow your guidelines, but when you do, make sure you're documenting why you're doing what you're doing. All right, so indication of your pacing. What are the millivolts that you ended up using? What's the rate that you ended up using? And again, the vital signs. Document the vital signs before and after you started to pace that patient. Medication. This is one of the more important ones, I think. A lot of times we just kind of override it and say you gave a patient nitroglycerin sublingual. You're not putting down the dosage of it, right? Or you just say nitroglycerin. You don't even say the route, okay? So make sure you guys put down the indication why you're giving that medication. The dose. Make sure you document milligrams, micrograms, okay? And the route, IM, IV, PO, IO, whatever the case may be. And again, the patient's response to what you're doing to them, okay? Fracture and immobilization, very basic here, right? Maybe you're just immobilizing a limb. Maybe you're doing a full immobilization on the patient from a motor vehicle collision or a fall or something like that, right? But document your method, all right? Did you do a pillow splint? Did you do a traction splint? Did you do full spinal? Did you do just a C-collar? All that type of stuff. And one thing that I've noticed when I used to do QA is that a lot of people would not document the pulses and motor and sensory before and after immobilization, okay? go ahead and do that, guys. It's only a couple little lines to type in there, but make sure you put down your pre and post immobilization for your pulses, motor, and sensory, okay? What about your 12 leads? This is something, again, too often we do it, we print it out, we don't document in the notes what it is that we're finding unless we see a ST elevation. But it's important. If you find nothing, write nothing. Put your rhythm down, put the rate down. All right, look for nodal or bundle branch blocks. All right, and also any of those ST segment changes, elevation, depression. Okay, put all that stuff down, guys. All right, go ahead and evaluate the EKG. All right, and you might have to do hemi blocks and stuff like that, depending upon how deep you want to go into this. Right, you want to, if you want to put you know, anytime access deviation, stuff like that. If that's what you're going to do, go ahead and do that as well. All right, but my suggestion is if you're going to do that with your 12 leads, be consistent and do it for all of your 12 leads. This way you can always go back and you know how you're documenting them. Okay, cardiac arrest. This might be kind of easy or kind of common sense, but remember, you want to document that initial rhythm when you got there, whether in VFib, VTAC, asystole, PEA, right? Put your treatment down that you gave. Was there any changes to the treatment, okay, or positively or negatively? Were they in VFib and went into asystole? Were they VTAC and went into a sinus or went to a PEA? Okay, go ahead and document your rhythm changes. If you end up pronouncing or you get return of spontaneous circulation, document your final rhythm. Was it asystole or was it a sinus rhythm? Was it a Y complex sinus rhythm? Whatever the case may be. And one thing that I always think is important too with cardiac arrest is to document your end-tidal CO2 as well, to show that you've got a good airway going on, that your ventilations weren't too fast, weren't too slow, okay, and all helps in the final documentation, okay? So just keep all that in mind, guys, when you're documenting your cardiac arrest. All right, there's a lot of stuff to document. It goes back even some of the stuff we've just talked about, the medications, the intubations, right? So make sure everything ties in together. Now, finally, guys, I want to talk about the patient refusal. Now, patient refusal to me puts us the most at risk, right? And I'm sure you've heard this before. Some of the things that I think are very key to include in your comments is your confirmation of the patient's decision-making capacity. All right, make sure you document that the patient was alert and orientated, they knew what was going on, and they were able to make that decision-making capacity. Ask them how many quarters make a dollar. Even ask them how to tell you the months backwards, you know, December, November, October, September. If they get halfway there or three-quarter way there, you know that they're alert, right? What day it is, things like that. You know, get their alert and orientation. Make sure that they can make decisions to refusal. Also, make sure you document that you explain to them the risks and the benefits of refusing or going to the hospital. Okay, even telling them that there's a possibility they could have permanent disability or even death. Okay, make sure it's very clear to them. You're not doing it to scare them, but you're doing it to make sure it is black and white and that they know the risks and the benefits of them refusing or of them going, okay? And then go ahead and confirm that they understand those risks and the benefits. And you want to document all of this information, okay? Yes, it's more documentation, but patient refusals often are more in-depth documentation, okay? Because you don't want there to be permanent disability or a death or something like that, and then it comes back that you did not explain those risks, you did not explain those benefits, and that you did not confirm the patient's understanding of all of this and their understanding of the whole decision-making process to begin with, okay? So important stuff there, guys. Finally, guys, stuff is as needed, right? If you're going to do a basic EKG, you're going to do a blood glucose. If you do blood glucose, let's say you do it for a hypoglycemic patient, document your blood glucose before and after you treat the patient, okay? Your pulse oximetry. Go ahead and document what it was on room air. If it was too low, document what was it on oxygen. Did you intubate them? What was it after you intubated the patient? Okay, document that as well, guys. All right? Guys, I know this is a lot of stuff here, right? And I hope you review this Monday minutes, in the future when you're thinking about documentation, and if you did something wrong and did something right, and maybe what you might have missed when you're documenting something. All very important information, guys, and I hope you can use these Monday minutes. Okay, go ahead and review this stuff, come back to look at it, and refresh your memory on some great things that you can document when you're treating your patients. Okay, guys, listen, I have a great CD here if you're interested. This is Turbomedic Highlights. This is actually the first CD that I made, and this is exclusive content from the archives of Turbomedic. All right, some great stuff in here on geriatrics, asthmatic, neurological assessment, a practice exam, some resources on understanding the bones and EKGs and EKG lead placement, cardiology, conduction. All right, all great stuff, guys, and you can add this content to your EMS library. You can own this part of Turbomedic. All right, I know Turbomedic is a monthly fee, but if it's too much for you to join me as a premium member there, I get it, right? Things can be expensive, but at least do yourself a favor and own this small content from Turbomedic. Click this little link here and go get all the details about Turbomedic Highlights, this first installment. I'm getting great feedback on this, a lot of orders on this, so I'm excited about this, and I'm hoping that it's going to lead to more down the line in a series of Turbomedic Highlights. So go check it out. Click here for the details. Again, guys, hope you can use these Monday minutes here at EMS Office Hours. Have some minutes of your own. Send them over to me. It's contact@emsofficehours.com. Until next week, as always, Jim Hoffman, stay safe.